We'll go ahead and get started here. I'm going to cover the first bit, which is going to be the boring bit, and then going to turn it over to Dr. Jameson. And together we're going to kind of handle the second half of the presentation. But we're going to start off with the first half, going over the CDC guidelines for opioid prescription that were published in 2016. Little disclaimer, all the recommendations I'm about to share are based on the CDC guidelines. They don't necessarily reflect my personal practice, personal feelings. But it is what is recommended by the CDC for prescribing of opioids for chronic pain. So these guidelines were released in response to the opioid epidemic in the United States. The guidelines were meant for primary care physicians treating chronic pain, which was defined as pain lasting longer than 3 months. It did not, or 3 months after the natural healing process was thought to be completed. These recommendations are not applicable to acute pain, cancer pain, palliative care. And again, it was in response to increasing prescription rates of opioids, almost half of which are being prescribed by primary care physicians, and the increasing adverse events associated with opioids, and primarily addressing opioid use disorder. The DSM-5 classifies this as a problematic pattern of opioid use leading to clinically significant impairment or distress. And the three main issues with this are tolerance, dependence, and addiction. Tolerance being it takes higher doses to do the same pain relief over time. Dependence being withdrawal after acute cessation. And addiction, which is the desire for more substance, not wanting more pain relief, but wanting more substance despite consequences. So talking a little bit about the opioid epidemic, and again, this is related to the CDC guidelines in 2016. Opioid prescriptions quadrupled in the 17 years leading up to this recommendation, even though overall pain had not changed in that same time period. More than 40 people die every day from opioid-related deaths, which is more than 165,000 deaths from overdose from 99 to 2016. And they estimated in 2013 that there had been around 250 million prescriptions of opioids in the United States. So the CDC decided to release guidelines in an attempt to address this opioid epidemic. They evaluated data with the grade method and to basically grade what level of evidence for different recommendations. They sought expert opinion from primary care professional societies, experts in pain and pain management, state societies, and also those who are experts in guideline development. They also sought stakeholder comment from those most likely to be affected by these, including pain medicine, PM&R, and hospitals. So they wanted to first address 5 primary clinical questions and use the answers from those questions as the basis for the recommendations. We'll go through these questions one by one. First question is, do opioids work for long-term chronic pain? So they looked for studies comparing long-term opioid use versus placebo, versus non-opioid medications, versus no opioids. They wanted to look for the outcomes of pain, function, or quality of life. Not surprisingly, they did not find any studies that evaluated greater than 3 months of chronic severe pain in patients who were randomized to opioids or placebo. That study doesn't exist, nor do I think it will ever exist. You're going to have a hard time finding patients who are willing to participate in the study who are in severe chronic pain for a study lasting longer than 3 months, in which they may receive pain medications and may not. So most of the studies they found were less than 6 weeks of duration. So they didn't find any evidence to answer question 1. So their answer is there's insufficient evidence to support long-term opioid therapy, because there is none. There's no evidence showing that opioids work for long-term pain because it's never been studied. So that was their answer to that question. The second question was the risks of opioids versus placebo. They found a lot of evidence comparing opioids to placebo as far as side effects and risks. So they labeled this as type 3 evidence, which is observational evidence, randomized control trials with limitations. It's not great, but it's decent level evidence. They found, unsurprisingly, long-term opioid therapy increased the risk of opioid use disorder. The rates of disorder were, again, very, very low for no opioids, still very low for low-dose opioids, but higher still with high-dose opioids. Other factors that predicted this misuse, younger age, psychiatric conditions, higher doses, and I think Dr. Jameson is going to go into some more detail with this moving forward. They also found that being on opioids long-term increased risk of negative outcome. People on opioids have higher risk of fractures, higher risk of cardiovascular events, endocrinologic harms, whether it's ED, low T, androgen deficiencies, increased odds of road trauma from people driving on opioids, which may account for their increased risk of fracture. So their answer was there are definite risks to long-term prescription opioid therapy. The next question was talking about different dosing strategies. They labeled this as type 4 evidence, which is less than type 3. These are severe limitations to randomized control studies. And they didn't find a whole lot of definite answer here, but they did find that extended release has an increased risk of non-fatal overdose compared with immediate release, or ER had higher risk than IR. They didn't have any evidence that extended release worked better for pain control or function. But again, this was very poor evidence, a lot of mixed evidence. They had one study that showed methadone had a lower risk compared with morphine, another study that showed there was no significant difference, and another study that showed methadone had a higher risk compared to morphine. So 3 different pools of data showed 3 completely different outcomes in different types of extended release medications. So they found there was insufficient evidence to support one strategy over another. And these different strategies are, liberal dose escalation, maintenance of current dose, opioid rotation, whether you're using extended release, immediate release, or both, scheduled dosing versus as needed dosing, whether or not you discontinue or keep on long term. They didn't find any evidence comparing one strategy to another. So their answer, there's not really evidence to support one method over another, but the extended release may be more dangerous. So their next question was they wanted to assess the accuracy of instruments predicting the risk. How can you predict which patients are going to have a negative outcome from opioids and which ones are not? So they looked at a lot of different risk tools. They looked at the ORT, the SOAP-R, the brief risk interview. All of these had really low sensitivities, really low specificity. One of those is supposed to be specificity. Sorry about that. They didn't work very well at predicting opioid abuse. They also looked at mitigation strategies for evaluating the effectiveness of these tools. Again, the risk assessment tools, opioid management plans, patient education, all of these things. They didn't find any data evaluating how effective they were in predicting the risk. And then the last question was, does prescribing opioids for acute pain increase the risk of long-term opioid use? And the answer is yes. So using opioids for acute pain does increase the likelihood of long-term use of opioids. This is for both minor surgical pain and non-surgical pain. And that higher doses of opioids for acute pain carried higher risk for long-term opioid use. So they took these questions, these answered, and they further evaluated with a contextual evidence review. This is looking at clinical research, applying them to the answers to these questions. They focused them into 4 different topics, and we'll go over those one by one. They did not formally rate the level of this evidence. A lot of it was evidence that didn't make it into their first data review for the primary questions because it is expert opinion or anecdotal, things like that. So they broke it down into 4 main categories of contextual review. The first being looking at non-pharmacologic, which is things like physical therapy, interventional procedures, and looking at non-opioid pharmacologic treatment and assessing what are the other options besides opioids. And I'm going to cover this real briefly because Dr. Jameson is going to go into more detail in the second half of this as far as different medications and different non-pharmacologic things. But real briefly, cognitive behavioral therapy, other multimodal psychologic therapies, exercise therapy, they're all very safe and reasonably effective at treating chronic pain. They briefly looked at interventional approaches, and the CDC found that it could be appropriate for certain conditions, but they also were concerned with risks of interventional approaches and said that the risk must be weighed against potential benefit. And looking at the medications, again, there's a lot of different options besides opioids for pain management, and I'm going to basically just let this slide be up here for completeness sake for the CDC recommendations, but knowing that Dr. Jameson is going to cover a lot of these in more detail here in a little bit. They also wanted to look at the benefits and harms of opioid therapy. So again, this is more evidence beside what they already had for their primary clinical questions. They found that extended release opioids carry serious risk. Methadone in particular has a high risk of overdose. A lot of this, I think, is a bit unfair towards methadone because it's used to treat opioid use disorder. And so you're going to have addicts that are taking methadone, which are at higher risk for overdose. But that being the case, I think methadone was responsible for a very disproportionate rate of overdose compared to what percentage of it is actually prescribed. It makes up less than 1% of total opioid prescriptions, yet it's responsible for around 20% of overdose events. And this is due to a lot of different aspects, but primarily because methadone has a long half-life and variable metabolism, so it's really difficult to predict how much methadone will build up in your system. They recommended immediate release, extended release only for pain requiring daily, around the clock, long-term treatment. They recommend trying everything else first. And they were concerned that when you schedule opioids rather than keep it as needed, you tend to get higher doses with scheduled than when you leave it as needed. They also found that overdose risk is dose dependent. The higher dose you're on, the higher your risk of overdose, which again is not surprising. They also looked at co-prescription and found higher rates of overdose when opioids and benzos were prescribed together, and higher rates of overdose with opioids prescribed by multiple different providers. They looked at what populations are at the most risk. So this includes people with sleep apnea, mental health conditions. Again, noting that with depression, it's difficult to distinguish between an accidental overdose and a suicide attempt as far as the risk of opioids go. They also found patients with renal and hepatic insufficiencies increased the risk. Again, the medication can build up in your system if your metabolism or excretion is reduced. They found risks for pregnant women, both to the mother and the unborn child, and anyone with a history of substance use disorders. They looked at risk stratification tools, prescription drug monitoring programs in Texas. This is the Texas PNP Aware. They provide information about both who's prescribing the medication and what dose it is. And those are two of the most well-correlated risks to overdoses, the dose and how many prescribers. So it's really valuable information to help prevent harms of opioids. They looked at naloxone distribution. This is accidental overdose reversal. They found that it decreased rates of overdose in the community, and that methadone and buprenorphine used to treat opioid use disorder resulted in decreased heroin use and a better safety profile for these patients as well. They also looked at what do clinicians and what do patients think about opioids, just for more of a well-rounded understanding of opioid prescription in the United States at the time. Looking at clinicians, a lot of clinicians lacked confidence to prescribe opioids, detect abuse, or discuss abuse with their patients. A lot of physicians had positive opinions of opioids, that it could increase your quality of life, but most providers consider prescription drug abuse a serious issue in their community. And again, this is from before these recommendations were published 5 years ago. But at the time, most primary care providers did not routinely use prescription monitoring programs, urine drug screenings, or controlled substance agreements. When they looked at patients, at that time, patients weren't as familiar with opioid. They were more familiar with the term narcotic. A lot of them feared addiction. And really, most of their preferences in regards to their opioid medications were related to side effects rather than the pain relief that they were getting. And in higher doses, you see reliance on the medication despite ambivalence about relief. And you see this all the time in patients who are taking really high doses. They'll tell you they're miserable, they're 8, 9, 10 out of 10 pain, but they need their medications. They absolutely need those medications, even though they're still in pain and miserable. And so you do see that with higher doses. And lastly, they looked at resource allocation, the cost of opioids compared to other options. And there's cost related to non-medical use or opioid abuse diversion. They looked at the cost of strategies used to decrease the risk, things like urine drug screens, prescription monitoring programs. The overall cost of overdose treatment alone was $20 billion a year, and the cost was lower for non-opioid therapy when all these things were considered. So they used all this data to form recommendations, and they based these recommendations off three principles. The first is non-opioid therapy is preferred outside of cancer, palliative care, and end of life. When opioids are used, the lowest possible dose should be used to reduce risks. And number three, clinicians should always exercise caution when prescribing opioids and monitor patients closely when they do. And so they came up with 12 recommendations about opioid therapy, and we're going to go through them one by one and evaluate these recommendations. So The first three are about determining when to start opioids for chronic pain. And their first recommendation is opioids are not first-line therapy. That doesn't necessarily mean other options have to be exhausted, but that other methods are safer and preferred for management of chronic pain. They also say opioids should only be used if the benefits outweigh the risks, and they specifically talk about certain conditions where the benefit is unlikely to outweigh the risks, and that includes conditions of headache and fibromyalgia. And they also talked about if you are going to prescribe opioids, it shouldn't be opioids alone. It should be in combination with other modalities. You should look at concurrent mental illness. You should look at evaluating depression. You should look at the fact that other medications are rarely associated with overdose, and that opioids do reduce pain in the short term. But again, this is a running theme throughout the recommendations that there's insufficient evidence to determine whether pain relief is sustained long-term with opioid therapy. Same thing for function and quality of life. Their second recommendation is that you should establish goals with patients ahead of time, and that's both for pain and function. You should have these be mutually agreed upon. You should talk about how that progress is going to be evaluated, whether it's pain scores, activity tolerance, returning to work, things like that. You also should plan an exit strategy with patients. If you find that the risks outweigh the benefits and you decide to move away from opioids, discuss how that process is going to be achieved. And you should only continue therapy if the patient is improving. And again, insufficient evidence for pain or function benefit lasting greater than 6 months. Their third recommendation is that you should discuss risks with patients. They found that a lot of patients on opioids didn't understand the risks. They didn't understand the possible side effects. That they recommend explaining to patients that there's no evidence of long-term benefit. They also recommend emphasizing function as a goal over pain or pain score reduction, and that you should talk about the serious side effects of opioids, whether that be fatal respiratory depression, opioid use disorder, common side effects, more unusual side effects. They recommend discussing driving safety and discussing the risks of higher doses and the importance of compliance, that these medications are unsafe when they're not taken as prescribed, especially when they're overtaken. They also recommend, as far as patient and clinician responsibilities, that you discuss the increased risks of taking opioids with alcohol, other recreational substances, or benzos. They recommend that you discuss the safe storage of opioids to reduce risk to household members, and to discuss how you're going to monitor the patient, discuss urine drug testing, talk about whether you're going to prescribe Narcan or not, and in certain conditions, just determining whether a caregiver's response is necessary for safe use. So their next section of recommendations are all about opioid selection, dose, duration, follow-up, and discontinuation. So their fourth recommendation, use immediate release when starting. They prefer immediate release to extended release. Sorry about that. Extended release options are things like methadone, transdermal fentanyl, and anything extended release. There is higher risk of overdose compared to immediate release options, and that there's no evidence that it's more effective. Again, there's not really evidence either way. There was no study comparing them. Extended release medications are associated with a higher daily total dose, and methadone and transdermal fentanyl are especially high risk. And again, we talked about methadone with its variable metabolism. Transdermal fentanyl is one of those where it's going to keep providing medication. It's not something that you have to be there to take a pill for. You slap it on for 3 days. And if you're starting to build up toxic levels of fentanyl, if you don't realize it, well, the fentanyl is going to continue to accumulate. They do recommend avoiding combining immediate release and extended release medications. And briefly about abuse deterrent. An abuse deterrent is a label that indicates that the opioid is going to be difficult to convert into an intravenous opioid. This can be a combination medication where it's combined with an antagonist that, when injected intravenously, prevents the benefit of the opioid. There's also formulations that provide a pill with the ability that when it's heated, it globulates instead of melting to prevent intravenous use. But this does not prevent PO abuse. So if you see an abuse deterrent, it doesn't prevent PO abuse in any way, which again is the most common form of opioid abuse. Their fifth recommendation, use the lowest effective dose. And this again is reasonable. These are medications with known risks. They say that you should use caution at any dose, that you should start with the lowest dose. Some other patient populations that you should have caution with are patients over the age of 65, patients with renal or hepatic impairment. They also specifically stated that you should carefully reassess benefits and risks before escalating higher than 50 morphine milligram equivalents per day. The risk of overdose at 50 is reduced significantly from what it is at higher doses, and along the way, you should assess whether your goals are being met. They also specifically have this new guideline, again, new in 2016, to avoid increasing the dosage greater than 90 mmHg. This wasn't an arbitrary number. They based it off of the VA data that showed the mean dose of opioid prescribed at time of overdose was 98 daily morphine milligram equivalents per day. They recommend that, again, the benefits of long-term use are not established. Again, the recurring theme throughout, and that risk increases with daily dose. They also have a little plug here for considering consulting pain management when you get to this point. I would put a shameless self-plug saying you should consider consulting pain management much earlier in the process than that, but that's your decision to make. They also evaluated tapering doses for those at high dose. Again, they said you should explain to these patients that there's an increased risk of overdose with high doses. Higher doses for years requires much slower tapering and may even require pauses in that taper for them to acclimate to that new dose. And again, the dependence, it can be symptomatic where they're going to be in pain if they're not getting these medications. It can be physical where they're going to go into withdrawal without these medications. And it can be emotional. I mean, patients have, if they've been on high dose for years, they've been dependent on these medications for a long time. The next recommendation is to prescribe short durations for acute pain. Again, that long-term medically directed opioid often begins as treatment for acute pain that they never get off of. They recommend the shortest duration possible. 3 days will often be enough for some injuries. More than 7 days is rarely needed. And physical dependence can occur in the matter of several days. And every day that they're on opioids increases their risk of long-term use and their risk of dependence. They specifically address avoid prescribing extra medications just in case. And they also note that early exposure is correlated with long-term use and that acute pain can be managed without opioids. And again, this one seems more straightforward, but use immediate release as needed medications for acute pain, not extended release options for acute pain. And then they talk about evaluating benefits and harms frequently. They recommend evaluating benefits within 1 to 4 weeks of starting. And there's a lot of different tools that they looked at for this, one of them being the PEG assessment scale. You want to discuss, are your patients meeting their goals, discuss possible side effects, and that these should be evaluated frequently. So the CDC recommends every 3 months or more frequently, preferably in person and by the prescribing physician. If goals are not met, then consider taking them off of opioids rather than dose escalation. And as far as different tapering options go, there's not really one tapering option that was better than another. There's no literature to support one or the other. For more short-term use, 10 to 50% per week could be appropriate, and that's a really wide range, depends on how long the patient's been on it. If you're looking at long-term high-dose opioids, 10% may be too much. You may have to get creative in how you're reducing these patients slowly, gradually, again, with pauses in that taper for them to acclimate to the new dose. And all of this is to minimize symptoms of withdrawal, craving, anxiety, abdominal pain, diarrhea. You can read all those there. Trying to avoid that in tapering patients off of opioids. In the last segment of these 12 recommendations, we're talking about assessing the risk and addressing harms of opioid use. So different strategies to mitigate risk that they recommend using these before starting to evaluate risk for opioid-related harms. Again, there wasn't any one that was more effective than another, but they do recommend at least trying something. They recommend offering Narcan when there's risk factors present, whether that's higher doses, concurrent use of benzos, history of overdose, patients to be concerned about. These are more, risk factors. Sleep apnea, they recommend avoiding use in moderate or severe sleep apnea. Pregnancy, they recommend against it. A lot of risk associated with that as far as poor growth, preterm delivery, birth defects, neonatal withdrawal. The maternal all-cause mortality is higher in pregnant patients on opioids. talking about elderly patients with renal impairment or those with renal impairment in general, you can get greater accumulation. And so there's more risk in a smaller therapeutic window. Patients who have mental health conditions, they recommend addressing the mental health. Controlling mental health improves pain in patients. Patients with substance use disorder have a much higher use of overdose. Patients with history of non-fatal overdose, which is the only kind of prior overdose, they recommend reducing dose and discontinuation whenever possible. Their recommendation number 9 is review the PNP data. This, again, gives you access to control medications, whether you're getting dangerous combinations and benzodiazepines, check for high doses, look if they're getting prescriptions from anybody else. They recommend this should be reviewed at least every 3 months or every prescription. It's also good to calculate the total morphine dose. With the Texas PNP, it's automatic on the page, on the printout. It has their average daily NME amount. Also in Texas, this can be delegated. So if you don't want to be logging in and typing in the patient's name and date of birth, this can be delegated. So an office nurse or office medical assistant can access the information, print it, and you can review it very quickly before seeing patients. They also specifically address dismissal a couple times in these recommendations, and they don't ever recommend dismissing patients based on prescription data monitoring program or urine drug screen data. They're concerned that if a patient is dismissed, that could represent patient abandonment, and it could be a missed opportunity to provide care. I do think it's reasonable to look at a prescription data monitoring program, and this is not the CDC guidelines, this is me speaking here, that it's reasonable to look at it and say, look, if you're going to go to other providers and get other medications against what we've agreed upon, then I can't prescribe these medications to you safely. I'll still take care of you, I'll still manage you, but it won't include these particular medications, which ultimately usually results in the patient terminating you rather than you terminating the patient. But I do think it's important to offer services to these patients rather than just dismiss them. Their next recommendation is urine drug testing, urine drug screens. They recommend it be used before starting opioids and at least annually. A lot of members of their expert panel found this to be too long an interval and recommended more frequent. Others found that it was unnecessary to have in every patient urine drug screens. Personally, I think a case-by-case basis is more appropriate. There was no evidence assessing the effectiveness, but a urine drug screen can provide information that a patient is unwilling to provide. So if they're using unauthorized medications or substances, if they're not taking their medications and diverting it rather than using it themselves, and they're going to test negative on the urine drug screen, but they don't provide information about dose or frequency. So these results can be misinterpreted. There are common false positives. There's stigmatization for patients having to do a urine drug test. It makes them feel like a drug addict. Random tests can help destigmatize that, but everybody agrees that there is no true random urine drug screen. It's not really feasible to have it be a random process. Some recommend testing monthly, or at least collecting specimens monthly. The problem with this is it's more costly to patients, as insurance doesn't always cover the exams. And in my experience, any urine drug screen that's predictable is not beneficial, because patients can simply take enough medications to reliably test positive when they know they're going to be tested, and they can avoid behavior which could impact the urine drug screen if they know they're going to be tested. So more of a random or pseudo-random way of doing it, I think, is more likely to not be manipulated by patients. There are different types, from the relatively cheap to the more expensive. And again, they recommend not to dismiss patients based on these. It could constitute patient abandonment and have an adverse effect on patient safety. If you're going to dismiss them, well, they may go get their opioids somewhere else. Again, I think it's also reasonable to tell patients, you're not taking these safely. I can't prescribe them to you if you're not going to take them safely. I'm going to help take care of you. We're going to get you through this, but it's not going to improve these medications anymore. All right, just a couple of quick recommendations left. Recommendation 11, avoid benzodiazepines when you're prescribing opioids. Both cause central nervous system depression. A large proportion of overdose deaths, patients were on both. And lastly, offer treatment, at least to either offer it or arrange treatment for opioid use disorder should you have a patient that engages in aberrant behavior and is abusing opioids. Both buprenorphine and methadone have shown to be effective at preventing relapse, and can be safe options for patients with opioid use disorder. And again, in conjunction with mental health and addiction specialists, they also touch on naltrexone therapy, which is a daily medication that's taken in order to prevent the patient from seeking out opioids. Requires a very motivated patient and daily administration of medication. So the conclusions, the recommendations are based on best clinical evidence, knowing that that evidence was not very good. It was interpreted and informed by expert opinion, and they say that additional research is needed to fill the gaps. So my summary for this is these recommendations were built in response to the opioid epidemic, and they found that these medications have known side effects, known risks, and there's no study showing long-term efficacy compared to placebo, nor will there ever be. I do think some patients do get long-term benefit. That's me talking. That's not the CDC guidelines. But the greatest possible caution should be used. We haven't studied the long-term benefits, but we know about the long-term risks. So that's kind of the end line on the CDC guidelines. And now I'm going to turn it over to Dr. Jameson, who's going to talk a little bit more about pain management in general.
All right. Thank you, Dr. Sweet. So again, my name is Grant Jameson. I'm a pain management physician at Hendrick. My clinic is located at the Hendrick Medical Plaza on Buffalo Gap Road, and I also have outreach clinics at Eastland Memorial Hospital. I go there once a month, and also Rolling Plains Memorial Hospital in Sweetwater. I go there once a month. And I have no financial relationships to disclose. We'll be talking about some devices at the end of this talk. So the next section of this presentation is about identifying drug-seeking behavior in a patient that comes to your office. And just a definition here. So opioid misuse is something that we always want to have on our minds. It's any use of prescription medication that is outside of the manner it was intended for. So we're all well aware that patients can overuse the medication when we prescribe it. They're not using it as prescribed. They may be using it to get high, diversion we talked about, and urine drug screens as a way to kind of identify that. Having multiple providers, and then the concurrent use of alcohol, illicit substances, and non-controlled medications as well. So again, risk factors, these are things that we're looking for in opioid misuse patients, and the two at the top are the most important. So if a patient has a substance use disorder already, and this includes tobacco, that puts them at higher risk for misuse. And also a family history of substance use disorder as well. And you can read these bottom four here. These are also generally considered to be risk factors for developing opioid use disorder and also for overdose potential. Moving forward, ways that we can identify and the management of misuse. So we all have clinical responsibility if we're going to be prescribing controlled substances to monitor our patients. And a universal precautions approach is what is in the literature and what we use to kind of standardize the prescribing and the monitoring framework. It's recommended if you're going to be prescribing narcotics. So this is a list of the universal precautions, and we're going to kind of discuss each one as we go down the list here. So you must document at least each visit. You want a history of substance use and mental health. Those are huge factors for opioid misuse. And then physical exam. So you want to look for evidence of intoxication when they come into your office, oversedation, signs of withdrawal, or any findings that may indicate that they're using these medications intravenously. So if they have track marks, if their nose looks like they might be snorting it, if they have redness around their nose, septal deviation, stuff like that. We want to document our medical decision making and come up with a plan of care. Regular follow-up, Dr. Sweet talked about, but generally every 3 months is recommended. You want to see them more frequently if they're high-risk patients, as identified before, or if you're making a dose change. You want to see them, the next month, just to make sure that they're not having any signs of overdose or side effects that may need to be addressed. And then the opioid contract. So addressing misuse, you need to have a well thought out plan for how to respond for the evidence of drug misuse. It needs to be communicated before you start the opioids. That way basically the patient knows what to expect, they know what their expectations are, and it avoids any accusations of prejudice towards the patient should you have to dismiss them or stop narcotic therapy because of them not following the plan that you discussed. And so here's the opioid agreement form. It basically outlines the responsibilities of the patient and the provider. It outlines how prescriptions will be given. It talks about the monitoring that will be used, if that'll be urine drug screening. And there's little evidence that this actually decreases opioid misuse, but it's mainly there again for the patient's expectations of what they can expect moving forward with the narcotic prescribing. So Waddell's signs you may or may not have heard of before, but these are signs that you can use during a physical exam that, as underlined here, may detect malingering in a patient with chronic low back pain or back pain in general. Classically, they were used for non-organic component of chronic low back pain or psychological component of low back pain. We use them for trying to identify malingering patients. So they're grouped into 5 categories, and the presence of 3 or more are positive tests. So category 1, you have 2 in this category. Superficial tenderness. So if you're palpating the patient's back and they are exquisitely tender to palpation by superficial touch, over their cervical spine, their thoracic spine, and their lumbar spine, it could be an indication that they may be exaggerating their response. Non-anatomical tenderness, this is during deep palpation. They're exquisitely, painful all over their body when you're just pushing on their muscles, let's say, if you're pushing on their traps looking for some mild fascial pain or muscle spasms. And then you move over and push on their spinous process and you get the same response. Those are 2 completely different anatomical areas, and they shouldn't elicit the same pain response. So that's kind of what that's indicating. Axial loading is part of category 2. So downward pressure on the top of the patient's head elicits lumbar pain. This should elicit cervical pain if they have cervical pathology, but it shouldn't elicit low back pain. Acetabular rotation. So this is where you are standing behind the patient is standing, you grab onto their left shoulder and their right hip, and you rotate their axial skeleton at the same time with their feet planted. This should not elicit any type of pain because the axial skeleton is staying in line and there's no rotation being done. So that's what acetabular rotation is, another sign. This one is probably the one that I use the most if I am curious to see if there is any type of malingering going on. So we do the straight leg test frequently. The formal straight leg test I do lying down, as you can see in the picture here. The patient may have some radicular pain on that test, may be positive. When I have them sit up, I act like I'm examining their knee and I do the sitting straight leg test, and they may or may not have that pain response. If they don't, then that would indicate maybe that they are malingering. If they have the same response, then it could be a true radiculopathy. Category 4, so regional sensory disturbances. We're looking for a stocking-like pattern of distribution as being not something that would be dermatomal in nature and could be a sign of malingering. So you have to take into account that some patients may have peripheral diabetic neuropathy, which does come in a stocking-like pattern. And other etiologies of stocking-like nerve pain, but if they have a herniated disc and they're complaining of a shooting pain down their leg, it should be in a dermatomal type pattern as seen here. Also with the weakness, so during motor testing, you should have locking of any maneuver that you're doing if they're strong, or a gradual giving away if it's weak. There should be no cogwheeling. There should be no immediate giving away of muscle groups. It should be either strong and locked, or it should be locked and then gradually give away if it's weak. So if they're cogwheeling, then that might be a sign as well. Overreaction. So this one we see quite a bit in patients who are malingering. So during physical exam, they may be exquisitely tender to palpation, positive straight leg test, all of these signs, and then when the exam is over, they may jump off the table, put their shoes on, bend all the way down, and nothing is painful to them. So just kind of observing the patient after the formal physical exam is over can be a strong correlation because they don't they don't believe that they're being observed for these types of things at that time because the physical exam is over. So they may display these types of things. So those are the Waddell signs that you can keep in the back of your mind for identifying malingering patients. Next, we're going to talk about the appropriate indications for opioid therapy. So again, we harp on this quite a bit, but everything in medicine is about weighing risk and benefits. So part of that should be opioids should be combined with non-opioids and non-pharmacological therapies to achieve the therapeutic goals with the lowest effective dose. This is kind of the overview of what we try to do in our pain practice here. So multimodal medication therapy, physical therapy, targeted injections, and then alternative medicine. Opioids should only be used when other alternatives have not provided relief and pain is adversely affecting the ADLs and quality of life. And then again, weighing the benefits and harm. So we're going to go over how do you do that. So weighing the benefits and harms. You want to look for risk factors for overdose. I highlighted benzodiazepines here because of the overdose deaths involving opioids, about 30% involved benzodiazepines. And that's based on the National Survey on Drug Use and Health, 2016 and 2017. And benzodiazepines have an additive sedative effect and also respiratory depression effects. And so it can really put them at high risk for an accidental overdose. And then history of overdose, I underlined here, that also puts them at a very high risk for a second or third additional overdose. And it can be due to a number of reasons, non-compliance or misuse. And here's some other risk factors. Male Caucasian, aged between 30 and 54. Those are the three main ones from that list. Quick definition here, opioid use disorder. So in the past decade, Dr. Sweet talked about, it has increased sixfold. So it had gone up. It's currently coming down with the CDC guidelines, which is good to see. And again, this is the takeaway from this. The personal history or family history of alcohol or drug abuse is the strongest predictive factor for a patient that may develop a drug use disorder. And so when we look at the risk assessment for overdose and misuse, we divide these two things into overdose and misuse. There's certain screening criteria that I'll get into on the next slide about how do you identify this. And here it is. So the SOAP questionnaire, it's a 14-item self-administered form. Greater than 6 identifies 91% of patients at high risk for overdose. So this one's used for overdose. This one is used for misuse. And there's 5 questions here, as you can see. So I'm going to show you a screenshot, and you can, if you want to take a picture of this, you can, but this is for overdose. So risk factors associated with outcomes, adverse outcomes related to opioids. Benzodiazepines is at the very top of that list. And again, the history of active substance use, and then the list goes on from there. So all of these things will contribute to the patient being at higher risk. And you, again, 6 or more will be 91%, will identify 91% of high risk patients. That's for overdose. This one is for opioid abuse. It's listed on here. But basically, I want to point out that males, again, are at higher risk. So their numbers in these 2 categories are higher. So if they are using alcohol or illegal drugs, those points are higher for male just because males are higher in general at risk. And psychological diseases. So ADD, OCD, bipolar, schizophrenia, depression. These are the psychological diseases that you should be on your radar when you're thinking about stratifying a patient risks and benefits. These are the ones that put them at higher risk for opioid abuse. I just wanted to talk about tramadol real quick because I see a lot of patients that are on tramadol. I think it's an excellent medication, but I wanted to point out that it does have SNRI properties. So it puts patients at increased risk of serotonin syndrome and seizures if they're already taking SSRIs, SNRIs, MAOIs, or TCAs. So I caution myself when I prescribe tramadol if somebody is on any of these medications. I rather avoid it, but sometimes I use an SNRI or a TCA as part of the neuropathic pain medications, which we'll talk about. And it's dose dependent, but I recommend not starting tramadol in a patient who is on any of these and maybe considering a different opioid like Tylenol 3 or hydrocodone if you plan to use that as part of your pain medication regimen. And so here's the highlights of this section. Opioid therapy for the treatment of chronic non-cancer pain remains controversial. Opioid therapy should always be initiated as a trial with understanding that therapy will be discontinued if the harms outweigh the benefits. Opioids should be combined with non-opioids, non-pharmacological therapies to achieve the therapeutic goals with the lowest effective dose of all medications, and therapy should only be continued in patients who demonstrate that benefits do indeed outweigh the harms. So I'm going to talk a little bit about the medications here just to be comprehensive with this. So when I think about starting a pain medication in a patient, I want to identify if they're having nociceptive pain, neuropathic pain, and psychogenic pain. So we all know what nociceptive pain is. It's what people experience when they have any type of trauma. So you can have somatic or visceral. Usually somatic is very discrete and intense, and visceral is usually diffuse and poorly localized. You can think of maybe gallbladder pain, how it wraps around the side and to the back is very poorly localized there. But first I want to talk about the neuropathic pain because this is largely what we see and what we try to optimize for pain medications in addition to the other ones, but this could include diabetic peripheral neuropathy, radicular pain, post-herpetic neuralgia, complex regional pain syndrome, and other neuropathies. So the medications, TCAs, most of the data is based on the International Association for the Study of Pain treatment guidelines from 2015. They mainly looked at amitriptyline because it was the lowest number needed to treat, and it was also cheap. So things I want to point out with the TCAs, you have two different classes. You have tertiary amines and secondary amines. The tertiary amines, which amitriptyline is in, have a lot of side effects. Okay, I'm not going to go through them all, but you want to caution prescribing these in patients who are over 65 if you're using this as a neuropathic pain medication. Nortriptyline is preferred in these patients. So if I have a young patient, I will think about amitriptyline. If they're older than 65, nortriptyline is what I will consider. Has less side effects. SNRIs, so mainly duloxetine is what the studies were based on. And I want to point this out. So if a patient has depression or anxiety and needs treatment for that, but also you can identify that has neuropathic pain, duloxetine or TCA is an excellent choice. Should not really combine duloxetine with other SSRIs, of course, for serotonin syndrome risk. Duloxetine is really my preference when I go to my choice between a TCA or an SNRI. Duloxetine is my go-to first, and if they fail this therapy, then I'll consider the TCAs, mainly because they have less side effects, as you can see here, less frequent than the TCAs. And a lot of times I have patients come to me on an SSRI and identify they have neuropathic pain, and I'll just switch them over to this for the added benefit of the neuropathic pain control in addition to treating their depression or anxiety if it's appropriate. And then again, tramadol has SNRI properties, so caution if they're using duloxetine or TCAs. Gabapentin. So I combined either a SNRI or a TCA with one of the gabapentinoids if they have neuropathic pain. And the side effects are here. These are the main side effects. I start my patients at 300 3 times a day. That's my starting dose. Unless they're over 65, then I'll start them at 100. They're more susceptible to side effects if they're over 65 is the common thing here. But my starting dose, 300 3 times a day. I see them back every month and I titrate them up. And I titrate them up about 300 at a time. So I'll put them on 600 3 times a day. If they report back that they're having side effects, then we'll go back down, but I continue that until I get the therapeutic response I'm looking for in pain control. The max dose here is 1200 3 times a day. If they fail gabapentin, then I move on to Lyrica. And the reason I start with gabapentin is because Lyrica is a controlled substance and it has more potential for abuse and physiological dependence. And so I start with gabapentin. If they fail gabapentin or they don't have a response to gabapentin, then pregabalin will be started. And it has less side effects than gabapentin, which is nice, but again, it's a higher risk medication to start. And the dosing regimens, I usually start patients on neuropathic pain, 75 milligrams twice a day, and then I'll increase it to 150 twice a day if they do okay. You can go all the way up to 300 twice a day. For diabetic neuropathy, the dosing is a little bit different, as stated there, but this is largely how I prescribe the pregabalin. Then we have some topical agents. These are mainly useful in my postherpetic neuralgia patients. Also, if I get consulted for acute post-surgical pain, I will use lidocaine patches in my multimodal pain management regimen. I'm not going to talk too much about those. So cannabis is something that has been coming up in the pain literature more frequently. A lot more studies have been published on it. So I just wanted to talk about it briefly, just in case anybody was curious, but cannabis is rarely prescribed in the pain management world. What is prescribed, and we prescribe this in New York, is selective cannabinoids. So you can prescribe THC, you can prescribe CBD, and you can prescribe a mixture, 1 to 20 ratio of any of those. And that's where the dosing comes into play. And this has gained a lot of popularity for the treatment of neuropathic pain specifically. There's a lot of literature to support this. So the cannabinoid receptors are linked to pain modulation, and activation causes an inhibitory effect on pain responses. We know that from the literature. Here's a meta-analysis that I pulled out of 11 randomized control trials, basically showing that those that received the selective cannabinoids, as I mentioned before, they had a reduction in mean numerical pain scores, and they had improvement in quality of life and sleep. There were no major side effects. I will point out that this was clinically small, and there were a lot of limitations to 11 randomized controlled trials. So again, more larger, better controlled randomized controls trials really need to be done on cannabinoids in order to be a standard of practice. And then I'm just briefly going to put this slide up here. This also is a part of the multimodal pain regimen: NSAIDs, Tylenol, oral steroids. Sometimes we will give a measurable dose pack if a patient isn't wanting selective selective steroid injections. I'll just put them on a measurable dose pack for a few days and see if they improve. So just want to quickly talk about, this is the last part of our presentation, interventional treatment options that me and Dr. Sweet are going to talk about. So vertebral augmentation, spine jack, maybe you've heard of it, maybe you haven't, but this is a treatment that is for vertebral compression fractures. It was FDA approved in 2018. And so I just wanted to talk briefly about this. This is a procedure that we offer here. And MRI, when it comes to compression fracture, is the only one that you can really identify an acute fracture on imaging alone. X-ray and CTs can show you a compression fracture, but MRI with stir imaging is the one that will show you if it's acute or not. And this is what we kind of need to identify if their compression fracture will be amenable to a vertebral augmentation procedure. So you can see here with X-ray, you've got your compression fracture. There's also a compression fracture below it that you can see on MRI in the T2 weighted. Two compression fractures. Stir imaging will show one's acute, the other one is chronic and healed. So this one we would treat, this one we would not treat. This is not pliable, this is pliable bone. So why is this such a big deal to treat these things? Well, patients with chronic compression fractures may develop kyphosis, and this can lead to a downward spiral. So restrictive pulmonary disease, cervical degenerative disc disease. These patients have cervical facet disease, neck pain we have to treat, headaches, mechanical neck pain, all of these things. These really lead to this downward spiral if you don't treat it. So these are conservative treatments: bed rest, physical therapy, bracing, opioids. But if you have a large compression fracture, 50% or greater, that leads to more adjacent level fractures if left untreated. And you can see decreased lung capacity, impaired function. This downward spiral, it leads to higher mortality. So there's really a push to really treat these things, if they're large, quicker rather than conservative treatment and let them heal and become chronic compression fractures, which may lead to adjacent level fractures. So if you guys have your phone, you guys can scan this QR code. It will pull up the SACOS trial. This is comparing spine jack to regular balloon kyphoplasty, which I used to do, but now I favor spine jack based on this study because it was a very well study. And here are the numbers here. So spine jack versus balloon kyphoplasty, non-inferiority study, 12-month follow-up. And again, they got FDA approval for this in 2018. However, it's been in Europe for about 10 years, and they're currently in their third generation of this device, so it's really improved a lot. So this is what it looks like. Here's your compression fracture. You insert just like you would with a kyphoplasty with this non-deployed, and then once you're inside, you deploy it, and it looks like a car jack. That's why they call it spine jack. And basically, once the jacks are deployed, you leave the jacks in place and then you inject the cement. And that's the key to this procedure over balloon kyphoplasty. With balloon kyphoplasty, you have to deflate the balloon. You inevitably get some height loss and then you inject. With these, you leave the spine jacks in place and you inject the cement so it holds the height restoration there. So what they found was greater midline vertebral body height restoration compared to kyphoplasty and fewer adjacent level fractures. And that will avoid going down that spiral that we talked about. So quickly from the study, the spine jack system demonstrated a significant reduction in adjacent level fractures compared to balloon kyphoplasty in the study. It also demonstrated significant midline vertebral body height restoration compared to balloon kyphoplasty. And it also demonstrated a greater pain score. So that ultimately is what we're looking for as well, is a decrease in pain was greater than with kyphoplasty at 6 months and 12 months. If you look at these studies here. And in conclusion, the SACOS study confirms that the spine jack system is superior ability to restore vertebral body height and reduce adjacent level fractures. And this is the conclusion that led me to want to use spine jack. And it's what I use in all my patients who are referred to me or who I identify to have a compression fracture, because I believe, and firsthand experience, I think it gives greater outcomes. At this point, I'm going to pass it on to Dr. Sweet. He's going to talk about new FDA-approved indication for spinal cord stimulation and intrathecal drug therapy.
All right, so intrathecal drug therapy, the approved drugs, intrathecal morphine, ziconotide, and baclofen. Other drugs that are commonly used but are off-label that I'm not endorsing or suggesting, but they are out there: hydromorphone, fentanyl, bupivacaine, clonidine, and others. These are especially effective in patients with life expectancy of 3 months or less. Several studies have demonstrated that life expectancy with intrathecal therapy is better than with oral opioids because you've reduced the side effects. So the advantages of an intrathecal drug therapy: you substantially decrease the dose of medication because the action in the intrathecal space is profoundly stronger than if it is IV or PO. So you also minimize systemic side effects, and you decrease the risk of abuse because the patients don't have any control over it. There are some systems that allow a patient bolus, but you can set limits on it, and they get as much medication as you program the pump to deliver. They don't have a pill bottle that the patients are reliant on to take appropriately. So specifically for cancer pain, there are some studies that show intrathecal drug delivery allows patients to tolerate a more aggressive therapy of chemotherapy and radiation with better pain control, so that they have better outcomes from their cancer treatment as well. This is indicated for patients who have side effects from the other ways that opioids are delivered and can't achieve adequate analgesia despite high doses of opioids. And then real briefly, we're going to talk about spinal cord stimulation. I know we're running out of time here. Mechanism of action is not fully elucidated. Originally, there was the gate control theory, and that's kind of how a TENS unit works, where if we stimulate nerves that are carrying painful stimulus, if we stimulate it with a non-painful stimulus, then they can't carry a painful stimulus and you'll get pain relief. That's not really how it works. There's a lot of different theories. Dorsal horn intraneural innovation is one, glial cell activation is another. We're finding out more and more about how it works every year, but we know it works. And new waveforms, including burst and high frequency, are showing a greater pain relief than your traditional tonic therapy. It's showing more sustained pain relief. We're getting really good outcomes with a lot of these patients. So FDA-approved indications for spinal cord stimulation, post-laminectomy syndrome, or what used to be failed back surgery syndrome, complex regional pain syndrome, ischemic limb, refractory angina, and phantom limb pain. This year, there's a new FDA-approved indication for high-frequency spinal cord stimulation, which is painful diabetic neuropathy. So the Senza trial was originally for low back and leg pain. They did another trial specifically for painful diabetic neuropathy. This is with high-frequency stimulation. Nevro is the company that has a proprietary patent on high-frequency or 10,000 hertz spinal cord stimulation. And they've assessed the effects of using this therapy for painful diabetic neuropathy. There's a lot of data here. This is their inclusion criteria. So nobody with a BMI over 45. They wanted at least 5 out of 10 pain with a hemoglobin C less than 10%, which is going to be most of our diabetic patients, and nobody on super high dose opioid therapy. So what their primary endpoint was 50% reduction in pain. And so they randomized the patients to conservative alone or conservative medication management with spinal cord stimulation. The group without spinal cord stimulation, 5 out of 94 patients achieved that 50% pain reduction. And in the spinal cord stimulation group, 79% of the patients, so 79% as compared to 5%, with a pretty good confidence interval with a low p-score. So this is a great option for patients with painful diabetic neuropathy. It's not a medication. It's not anything that's going to give them negative side effects. And it's early on in the game. There's not a whole lot of long-term data on it, but it's really promising, and patients are getting a lot of good relief. You know, looking at pain scores, the reduction from the baseline of 7 to 6.9 with conservative medications, but including the high frequency stimulation went from 7.6 to 1.7 I mean, on average. So really profound impact on patients that we're starting to really ramp up, and it's something we're really excited about. So that's that one there, and that is the end of our presentation.
So we'll open it up to questions if anybody has any questions.
It looks like there is a question in the chat box, maybe more than one. Let's see. Scroll down a little bit. How do you order spine jack? Orders directly to you. Getting treatment for our patients with compression fractures is very difficult in the big country area.
Mm-hmm. Yeah, so you can just send the referral, the patient over to our office, and I make it a priority to get those compression fractures treated as soon as possible. So just refer them over to my office, and we'll evaluate them. We'll make sure that they have an MRI that shows that they have an acute rather than a chronic compression fracture. So an MRI is usually wanted. And then we'll get them on the schedule to get it fixed as soon as possible.
Honestly, a phone call to our office would probably expedite that process.
That's true.
Significantly. So if you've got somebody who's really in severe pain who you need vertebral augmentation for a compression fracture, I would go through the referral process, but I would call our office and let them know about the patient, and we'll get it in.
That's exactly right. Just give us a quick phone call, and we'll get them on the schedule to be seen and get their compression fracture situated as quickly as possible.
Okay. Let's see. Unless that physician or has a follow-up to that, there's one other one in the chat box. It says, I have had several patients on Adderall who tested positive for methamphetamines on the urine drug screen. Is this expected or not?
Yes. So a lot of stimulant medications like Adderall can test positive for methamphetamines. Honestly, if a patient has a cold and is taking a significant amount of pseudoephedrine, that can also cause a false positive for methamphetamines. It's another reason why I don't think patients should be dismissed for a false positive. I think you should bring the patient in, evaluate them, talk to them for just a positive response. It very well could be a positive a false positive. And in a patient with Adderall, I would expect positive for methamphetamine on their urine drug screen for sure. You can pursue further confirmatory testing. You call the lab that you sent off the urine drug screen for and request a confirmatory testing with gas chromatography. I think here at Hendrick, our lab is sending them to Utah for those tests, and they can give you a more detailed breakdown on not just positive for methamphetamine, but more specifically, what exact drug it was and in what concentration. And that I recommend that for anybody who has a positive response that's unexpected and you think is a failed drug screen, send off for a confirmatory test with gas chromatography. I had a patient last month who I was prescribing hydrocodone for, and she tested positive for oxycodone. It was really surprising. She's a patient I've been taking care of for a long time. I sent off for a confirmatory testing, and the confirmatory testing revealed only hydrocodone, that it was just a completely false positive on the cheap urine drug screen that we use first pass. So before any disciplinary action should be taken, you should order a confirmatory test for that.
And I think getting to the point of addressing if they're actually taking Adderall versus if they're abusing meth as a drug, sent off for gas chromatography, they can identify the metabolites that will tell you if it's meth, if it's Ritalin, if it's Adderall, or any other amphetamine salt out there. So that would be the way to approach that situation.
Okay, that sounds, that's excellent. Thank you for that. And we do have another one. It says, do you refer compression fracture for spine jack before PT referral, and also any contraindications?
So I'll address. So when it comes to conservative treatment for compression fractures, it's a variable. So the things that I take into consideration are the amount of height loss. So if somebody comes in with a compression fracture and it's only 5%, I do more conservative treatment. So that would include bracing, physical therapy, and then medications, including opioids, because it is a broken bone, but short duration of opioids. So maybe 2 to 3 weeks, I would expect them to improve. If they're not improving and their pain is significant or getting worse, then I may consider moving on to vertebral augmentation. The contraindications for spine jack are the contraindications for pretty much any type of surgery, but if they have anticoagulation that they can't stop, that would be a contraindication. Ongoing infection would be another one. If they have significant retropulsion of the compression fracture into the spinal canal, it depends on the severity of that, but we'd have to take that into consideration as well. And then also, I usually try to get these patients started on osteoporosis treatment if they do have concurrent osteoporosis, and get that started as quickly as possible. But I think that covers the question. Are there any other questions related to that I didn't answer?
I think another aspect of that is insurance coverage, and for everything that we do, whether it's going to be spinal cord stimulation, spine jack, or other interventional procedures, a lot of insurance requires physical therapy evaluation before they'll authorize something like that. So that is something that you do run into.
Okay, thank you. There is one follow-up question here. It says, how fast do they see improvements in pain?
After what? Spine jack or?
It looks like it's after spine jack.
Oh, so spine jack also with balloon kyphoplasty, the pain response is almost immediate. So they will have a little bit of incisional pain. We make about a centimeter incision on both sides to get those trocars in. And so a little bit of incisional pain, but largely as soon as they get up from the procedure, their pain is relatively gone, and it's a great response, like 100%, 90 to 100%. They come back and they tell me that they don't have any pain unless they have some other pain issues going on. It's a very well tolerated procedure, minimally invasive, takes about 20 to 25 minutes to do. They walk out of the hospital the same day, usually pain free.